So we did everything with next available appointment, and so each panel would be able to tell, you know, who has diabetes, who has this, who has that. So I should be able to go and measure and say, oh, Dr. So-and-so, I see in your panel of 1,500 people, you have 113 diabetics. How are you doing with those diabetics? Let's measure you, and we'll pay for the performance of doing that. And that's the idea of it. And so I'm just going to run over here. So we have the measures that they'll be measured and accounted for. I must tell you that as we've done this, some of the best doctors, I remember, I think two of the best, one from Raymond and one from Pincher Creek, who have really been supportive, said, we're doing this stuff. But then they measured. And I remember Dr. Gelber, who's a leader, he got up there and he did his presentation. Now, I've just been measured for where I am with my tasks of diabetes, and I've just been measured for where I am in my clinic, for my panel, for those people. And he basically got up in front of the whole group like this and said, I'm sorry, I guess I suck. You know, it was just terrible. But it was a thrilling day for me to be able to have the physicians see that what they were doing was not perfect, that they could do better. And let me tell you, he's fast embraced the idea that he can have a team to help him to be able to do what should be done, and it's wonderful, and the other doctors as well. So there's just all types of measurements that we've done. What is the relationship now that if we have these physician clinics that are embracing the idea of having a core team help them taking care of a panel of patients to be able to take care of those fundamental things they should be doing for prevention and the maintenance of chronic disease? If they're doing that and the whole fabric of the system was doing that, what then should all the regional clinics be doing? And I'm sure you have the same thing. We have the diabetic clinic and the asthma clinic and the mental health outreach clinic and the you name it clinic. We have that for our regional health authority. So basically in the past, these folks have been doing a lot of stuff that's just been falling through because that natural fabric of primary care has not been taking care of it. The trouble is our congestive heart failure clinic, and we did statistics now as we put it together, with the 800 moderate and severe congestive heart failure patients that we have, they're taking care of 70 of them. That's really good for the 70, but what about the other 730? Unless they integrate with family practice and the primary care teams, we're still going to lose. It doesn't matter how good we are with 6 people if we have 106 that we need to take care of. So I kind of looked at it this way. You have the basic primary care at the bottom, but we have these teams, these core teams that I was telling you about. But then we have the referral. We have the specialty and the specialty teams. And then if it doesn't make it, goes to emergency and acute care. I would see if you took that little triangle inside, and whether that's mental health or diabetes or whatever, sure there's going to be some that are going to be in acute care. There's going to be some that need to be referred to specialists or the diabetic team or whatever. But the bulk of that work should be done by the core folks in those core teams taking care of the tasks that should be done for people with diabetes. But what happens, and what's been happening in my mind in Alberta, and I just assume that the rest of the world is somewhat similar, is that primary care acts as oh, you have diabetes, you better go here. Oh, you have this, you better go there. Instead of these teams that we have in the regions thinking that their number one role, if they're the diabetic team, is to educate those nurses and doctors in those primary care teams to be able to do all that they should be doing in the basic level of work that needs to be done, and then only being the point of the sphere, the top of the pyramid, to take care of those people that have severe needs. Okay, now we've got the 17-year-old pregnant diabetic. That's just a little more than that core team can take care of. I think you better go and see the specialist or the specialty team, rather than the specialty team being responsible for all because they can't do it. And this was just a model we're working on with a performance fund for those teams that do the things that we think are important, being patient satisfaction, access, continuity, prevention, and chronic disease. Just a quick one. I was asked by the government to go just in the past few weeks to visit a community of about 15,000 people They have 10 to 12 physicians. In their emergency, they had 27,000 visits. They had walk-in clinic, and they were so busy, they had to give up the obstetrical program, which was causing the political problems. They got to the minister, so now we have a problem. Jubber, go fix it. Where do you start? I mean, if you take a look from where I started, is there a shortage of doctors? Let me tell you, they thought there was. We're just so busy, we can't keep up. Well, no wonder you can't keep up. I mean, there's one doc there taking care of, what, about 1,400 or 1,500 people? That isn't so bad. But if every person's seen, I mean, the Lethbridge Regional sees 42,000 visits. The little town of 15,000 was seeing 27,000 visits. So they were maximizing the fee-for-service in the emergency department for a start. But what was doing? There's 4 times as much risk now of those people being seen again by their own doctor. Trouble is they're using a quarter of their resources to take care of the emergency. Then they set up a walk-in clinic because that's not good enough, so then they use more of the resources to take care of the walk-in clinic, so they have less resources to take care of it. And so you can see how these principles, if we could set up the system where the physician is fundamentally responsible for the population of 1,500 or 2,000 people, and then we worried about their continuity so they don't go to the emergency. For sure, I'm a doctor, you know, I want to be paid well for what I do, but I don't need to be paid for churning if I would be paid well for actually taking care of the folks. Fundamental, it has made a difference. We've decreased hospital visits, and there's just been tremendous embracement of same day, and not only in our clinics, but also in our regional programs. And on that note, I thank you very much for the time, and sorry I'm 5 minutes over. Thank you.